CDHB is to decrease the incidence of uncontrolled pain by 25% by March 2016. We are basing this in our surgical assessment and review area. So it's our a general surgery ward where patients are admitted through. We are looking at patients within the first 24 hours that are administered morphine, oxycodone or fentanyl any route. Our exclusions are patients who go to theatre within the first 24 hours or on a PCA, or if they are on opioids at home before they come in, and we are only looking at adults. So far the interventions we've tested, our main thing here was that our acute pain team had developed a set of dosing guidelines to help, in particular our junior staff, to know what is an appropriate dose of an opioid to start with. We had found that a lot of the juniors were coming in and they were dependent on staff around them to give them a guide of what to use. And our observation was that they were using high IV doses and low oral doses. So we rolled out some dosing guidelines. So we were looking at doses and pain scores in relation to that. We've also had a look at our nursing knowledge, assessed where they're at with analgesia and opioids, because we discovered with our opioid dosing guidelines, because we were advocating higher oral doses, we can advocate and we can have prescribed higher oral doses, but if our nursing staff are not comfortable with those doses, they won't administer that. They'll administer the lower end of the scale or below that. So we have looked at that, and then we are also looking at pain assessment. So we have guidelines that state if a patient's given an parenteral opioid that they must do OBS scores at 0, 5 minutes and at 15 minutes, but we don't have anything like that for oral opioids, and we are in the process of introducing assessing that at times 60 minutes, and then also documenting that on the OBS chart, whereas in the past that would have been documented in the clinical notes. So our main thing is looking at pain scores. Our idea is that if we provide dosing guidelines, our pain scores, the proportion of pain scores that are high should go down. So we are documenting how many pain scores are documented in the first 24 hours, and then what proportion of those are 3 or above. And we do a 0 to 5 pain score. These data is taken from when we introduced the guidelines. So we still have to go back and retrospectively look at a number of patients to see where our level was at guidelines, and then have a look here to see have we made a difference. It does look like it's still going up and down a bit. The other thing we're looking at too is if we believe that our guidelines are advocating higher oral doses, our oral morphine total milligrams divided by doses should actually go up if that is what's happening. Key lessons, dosing guideline, unclear how we've done with that until we have a baseline. We've had positive qualitative feedback from prescribers. Our nurses' knowledge, we've surveyed that, we've identified gaps and are in the process of putting together an educational package to deal with that. Pain assessment, so we've introduced the documenting the pain scores at 60 minutes and have the nursing staff document that on the observation chart, and that seems to be acceptable, and it's going to be what happens going forward. And we are moving next year to Patient Track, which is an electronic system for prompting patients' observations, and that is going to be rolled out next year. Struggles, I don't know about anybody else, but driver diagram, we're in our 13th, or actually now it might be the 16th version, so to get our head round what's a change concept versus everything else is difficult. PDS methodology, quantifying predictions in particular, we found quite hard. For pain, which is a subjective harm, it's very difficult to actually demonstrate, and as with anybody else, having the time resource that really is required to do this project as it needs is quite difficult. Successes, teamwork has been good. Our opioid dosing guidelines are in use. They're being incorporated into MedChart, electronic prescribing, and they're now in our Blue Book and in health pathways, and engagement of wider staff has been good.